Good morning, I am Dr. Muhammad Mamdouh, lecturer of nephrology and internal medicine. Today we are going to discuss and complete our general examination regarding hand examination and lower limb. To comment for hand examination, we should comment on the vital colors for the palm and dorsum of the hand, temperature, nails and nail beds, muscles, joints, abnormal movement, and rest of the arm. Vital colors, as we see, we especially look for pallor and cyanosis. We should look for palmar erythema, which is erythema at the basis of the fingers, thenar and hypothenar eminence with central pallor. Palmar erythema is erythema at the basis of the finger and thenar and hypothenar eminences with central pallor. Causes of palmar erythema include liver cirrhosis, pregnancy, thyrotoxicosis, and polycythemia. Skin, we should comment for if there is pigmentation, hypo or hyperpigmentation, or there is vesicles, macules, and papules in the hand, or there is petechiae purpura or ecchymosis. Also, we should comment if there is nodules in the palm of the hand, like, for example, Osler nodule or Janeway lesion. Osler nodule is present in the finger in two tips, in the thenar and the hypothenar eminences. It is nodules of 1 millimeter to up to 1 centimeter, and it is tender. It's here, tender nodule in the finger and two tips. What is Janeway lesions? It is present, it's macules. It is a macule of variable size. It's present in the sole and palms of the hand. It is not tender. This is important to differentiate and usually present in infective endocarditis patients. Temperature of the hand, we examine temperature of the hand by the dorsum of our hand to comment on pressure. Warm hands might be present in hot weather, exercise, fever, and hyperdynamic circulation like anemia and thyrotoxicosis. Cold hand is usually present in cold weather, anxiety, peripheral vascular disease, low cardiac output conditions. If there is excessive sweating or not, I should comment. Normally, it is normal in some patients that they have excessive sweating, but it's present also in some disease, in some conditions. And if it is, I should look for it is associated with cold or warm hand. If cold, clammy sweating, if there is sweating also associated with cold hands, it is present in conditions like hypoglycemia, it's a very important sign, anxiety, infarction, and heart failure. But if there is sweating is present with warm hand, I should think of thyrotoxicosis, fever, and toxemia. Nails, I should look for color of the nails, luster, shape, capillary refill, and nail diseases. Color of the nail, we might find what is called Merck line, it is here in case of hypoalbuminemia, or Poux lines with indentations, okay, with aging, heart failure, and shock. Also, an important colors, shapes of the finger is half and half nail, like here, half and half nail. Distal brown band, it is present usually in patients with chronic renal failure, or white nail, as you see here in case of liver failure. Also, we might find splinter hemorrhage, as in case of infective endocarditis, or dark lines in case of melanoma. Luster of the nail, normally the nails are clear and glistening, but if the nails are dull, opaque, and there is loss of luster, this is usually present where there is decreased blood supply to the nails, as in peripheral ischemia or peripheral vascular disease. Shape also is very important. If we found nail pitting and tripling, this might be present in case of psoriasis and inflammatory arthritis, as you see here. Nail pitting, it is abnormal. Also, there might be spawning, like a spawn, or what is called koilonychia, in case of iron deficiency anemia. Clubbing. What is clubbing? Normally, the angle between the nail bed, the nail plate, and the proximal nail folder is less than 160. There is an angle between the nail at the nail bed. Here, there is an angle. But if there is loss of that angle, or if the angle is more than 180 degrees, or obliteration of the nail bed, this is called clubbing. Clubbing is obliteration at the nail bed and loss of that angle. To examine clubbing, we do what is called window test. As you see here, we ask the patient to put his fingers against each other and look if we can see through these nails like a window. Normal, this is normal, I can see through. But in cases of clubbing, it is completely closed. I cannot see. So it is called window test or Chambros's sign. There is stages for clubbing. At first stage is obliteration of the angle. There is angle and here it is obliterated. This is the first stage, obliteration of the angle and filling of the nail bed. And then when it is increased more tissue, it will go up. At first there is proliferation and tissues obliterating the angle, and then it will more tissues, it will elevate up, cause increased convexity. It will make it like parrot peak appearance. Third stage, there is more tissues, but now it will go to the periphery, to the sides. In the previous stage it will go up and then it will go to the sides. It will make it like drumstick appearance. The fourth stage is called pulmonary osteoarthropathy. It is a radiological sign. We find that there is swelling of the distal end of radius and ulna. Pathophysiology, it's usually due chronic hypoxia or chronic toxemia. What are the causes of clubbing, which is a common question? Clubbing might be unilateral and it might be due to occupational causes or thoracic outlet syndrome, aortic aneurysm, arteriovenous fistula. It might be idiopathic or familial. And also clubbing has pulmonary causes. Most important is chronic suburethral lung diseases like bronchiectasis and bronchogenic carcinoma. They are the most important causes. Also there might be hypoxic core pulmonale, interstitial lung fibrosis and miliary TB. But the most important chronic suburethral lung diseases and bronchogenic carcinoma. Cardiac causes include infective endocarditis, which is called Bale clubbing, or congenital cyanotic heart disease, and it's called blue clubbing, blue for cyanosis, and atrial myxoma. GIT causes include inflammatory bowel disease, Crohn's and ulcerative, primary biliary cirrhosis, familial polyposis, and chronic diarrhea. And also hyperthyroidism might cause clubbing. For capillary examination, we press the nail bed to detect capillary refill time, and you will see it in clinical examination. Normally it is less than 2 seconds. When it is prolonged capillary refill, there is defective circulation. It is prolonged in shock state and in decreased perfusion. Capillary pulsations, peripheral planching of the nail bed, and if we should look for if there is pulsations or not, we might find it in case of aortic regurg. Muscles, we should comment for the muscles of the hand if there is wasting or not. As we see here, there is wasting in that hand. There is wasting here, as you see. So, wasting of the muscles of the hand might be caused by rheumatoid arthritis, neurological diseases at the level of spinal cord root or the brachial plexus, affecting the nerve supply to the muscles of the hand, or if there is ulnar or medial nerve supply, which are supplying the small muscles of the hand. When the nerve supply is lost, there will be wasting of that muscle because it is not used. We should also comment for joints. If there is arthralgia, which is pain in the joint, or arthritis is inflammation of the joint. And how to differentiate between arthralgia and arthritis? In arthritis, we will find signs of inflammation, including redness and hotness. Joints, we should comment if it is either a single joint, it's called monoarthritis, as in cases of gout, or it is polyarthritis when there is more than 4 joints are inflamed, as in cases of rheumatoid arthritis and systemic lupus. We should also comment if there is deformity in the joints or not. We have a lot of deformities like that in case of swan neck deformity, boutonniere sign. Also, we should comment if there is nodules or not. Nodules, for example, if we find nodules at the proximal interpharyngeal joint, it is called Bouchard nodules. And another nodules we might find in the distal interpharyngeal joint, it is called Heberden nodule. They are both present in cases of osteoarthritis. Another nodules might be rheumatoid nodules. At last, we should comment for tremors of the hand. Tremors of the hand, normally it is, of course, they are not present. But tremors might be fine tremors, as in cases of thyrotoxicosis, and we will see in clinical examination how to examine or search for fine tremors, as in cases of thyrotoxicosis, or coarse or flapping tremors, which is called astraxis, as in case of hepatic and uremic encephalopathy. Tremors might be fine tremors, as in case of thyrotoxicosis, and coarse tremors or flappy tremors or astraxis are present in case of hepatic and uremic encephalopathy, and you will see in clinical examination how to examine. Now we will go for lower limb examination. For lower limb, we should inspect for edema and swelling. Also comment for the skin, nails and muscles, joints, as we described before in the upper limb examination. But the most important for us is edema. Should also comment for pulsations like dorsalis pedis, popliteal artery and femoral artery. Should comment on temperature and joint examination and urological examination. Will be focused on lower limb edema. Edema is accumulation of fluid in the interstitial space, may be accompanied by accumulation of fluid in serous cavities like pleural effusion, ascites and pericardial effusion. It is best seen in lower limbs, in sacrum in bedridden patients, and in face in some causes, especially renal causes. It is important to understand the pathophysiology of edema. This is the blood vessel. As we described, that edema is accumulation of fluid in the interstitium space, accumulation of fluid here. So to the fluid to be accumulated here, it should be either pushed, there is increased force to push the fluid from inside the blood vessel to outside, or decreased force to pull it back to the blood vessel. To the fluid to be accumulated here, it either should be increased force to push it from inside the blood vessel to the interstitium, or decreased force to pull it back to inside the blood vessel. The force causing the fluid to pass from inside the blood vessel to outside is called hydrostatic pressure. It is called hydrostatic pressure. And the force which will pull back the fluid to inside the blood vessel, it is called the osmotic or oncotic pressure, which is mainly regulated by plasma proteins, especially albumin. So, how to make the fluid accumulated here? Increase the hydrostatic pressure, like in case of heart failure or hypervolemia, or decrease the osmotic pressure, decreased oncotic pressure, pushing back the fluid to inside the blood vessel. What will cause the osmotic pressure to be decreased? Hypoalbuminemia, decreased albumin, as in cases of decreased synthesis of albumin in case of liver failure, or increased loss of albumin in heavy proteinuria and nephrotic syndrome, or decreased intake of albumin in cases of malnutrition. All of these causes will cause decreased albumin, decreased osmotic pressure, decreased passage back of fluids to the inside the blood vessel. Another force which might play a role in edema is blood vessel permeability. Of course, if the permeability of the blood vessel is increased, the fluid will go outside, as in cases of allergy. Of course, what might cause accumulation of fluid here in the interstitium is obstruction of the lymphatics. Obstruction of the lymphatics, like in elephantiasis, or obstruction in the venous circulation, if there is venous thrombosis, in deep vein thrombosis or DVT. These are the causes and the pathophysiology of edema. As we described, force pushing out the fluid is the hydrostatic pressure. Force against which will make the fluid to go back to inside the blood vessel is the oncotic pressure or the plasma osmotic pressure, and blood vessel permeability. To cause edema, it might be increased hydrostatic pressure, or decreased osmotic pressure, or increased blood vessel permeability, or obstruction to the lymphatic pathway. Causes of edema, as we described: increased hydrostatic in case of volume overload, heart failure, deep vein thrombosis. Decreased oncotic pressure in case of hypoalbuminemia, in case of nephrotic, increased loss, starvation, decreased intake, liver disease, decreased synthesis of albumin. Increased capillary permeability in case of inflammation and angioneurotic edema, or lymphatic obstruction in cases of lymphedema. To comment on lower limb edema, we should comment if it is present or not, if there is edema or not. Second question, and it is the most important one, it is unilateral or bilateral. Unilateral or bilateral. This is very important. If unilateral edema, because unilateral edema has causes and bilateral edema has a different causes with a different prognosis. Unilateral edema, I should think first of DVT, cellulitis, and lymphatic obstruction. But in bilateral edema, I should think of the three major: heart, kidney, and liver. And of course, after that, I should think of allergy and malnutrition. And this edema, it is equal bilateral or not, it is pitting or not, consistency, severity, and upper level. It is up to what? It is up to the ankle, or up to the knee, or up to sacrum, or generalized edema, and the skin overlying that edema. These are the items which I should comment during lower limb edema examination. How I should examine? I should elicit edema by causing pressure against a bony prominence for 15 to 20 seconds. As you see here, we compress against the foot for 15 to 20 seconds, and then you look for that dimple here, or depression, due to edema, presence of edema in the lower limb. I can compress also this dorsum of the foot. I can compress over the ankle, and I can compress over the tibia and over the sacrum. These are the sites to compress: dorsum of foot, ankle, tibia, lower third tibia and the upper third tibia, and sacrum. Unilateral edema, as you see here, you should think of DVT, inflammation, cellulitis, and lymphedema, and might be allergy. Bilateral symmetrical edema, the three major: cardiac congestive heart failure, renal nephrotic syndrome, and renal failure. Nephrotic syndrome due to increased loss of proteins causing hypoalbuminemia and decreased osmotic pressure. Renal failure due to hypervolemia and salt and water retention. Hepatic liver cirrhosis due to decreased synthesis of albumin, decreasing osmotic pressure. Nutritional, protein, energy, malnutrition, decreased intake of albumin, decreasing osmotic pressure. Allergy, increased permeability of the blood vessel. Lymphedema is due to lymphatic obstruction, and myxedema also. Bilateral unequal, I should think of complication like cellulitis or DVT on one side. It is pitting or not, it's very important. It's pitting or not. Most of the edema are pitting, but if I found that it is not pitting, that while I compress it is not pitting with me, I should think of lymphedema and myxedema. non-beating. What are the causes of non-beating edema? It is somewhat difficult to compress it in case of lymphedema and mixed edema. I should also comment on the consistency. It might be soft, firm, or hard. Most of the cases are soft beating edema, especially in cases of hypoalbuminemia in nephrotic syndrome and cirrhosis. Cardiac edema, mostly it will be soft to firm, but hard edema will be present in cases of lymphedema. Sometimes we can comment on edema by degree of edema. It's 1+, 2+, 3+, or 4+. Sometimes I should also, when I'm examining for lower limb edema, the upper level of edema should elevate until the edema disappears. I should comment either this edema up to the ankle, up to the tibia, or lower third tibia, or upper third tibia, anterior superior iliac spine, or sacrum. If there is abdominal wall edema, clavicle, and facial edema, I should comment until I found the upper level of edema. Face edema, as you see here, most commonly, as I described before, it is present in renal patient and some patient with mixed edema and angioneurotic edema in anaphylaxis. Skin overlying edema, sometimes I should search for signs of inflammation, discoloration, and ulceration. Thank you. Good morning, I'm Dr. Muhammad Ndouh, and we will continue examination, our general examination. We will be focused now on hand examination and upper limb examination and lower limb examination, especially on lower limb edema. To examine hand, it's very important to remember the items. For hand examination, we comment on skin, subcutaneous tissue, muscles, temperature, joints, if there is deformity or not, and for clubbing, tremors, and if there is any tremors or clubbing and palmar erythema. Type. For the skin, we comment for the elasticity. There is no atrophy in the skin, no pigmentations are obvious. We should examine, to remember, it is bilateral examination. Regarding muscle status, there is no wasting of muscles. Temperature, we examine temperature or comment on temperature by our dorsum of hand. There is equal temperature, there is no warm. Okay. Then we comment on the knee, on the palm. There is no palmar erythema or nodules are present. Now we'll comment for clubbing. Ask the patient to do window test. As you see here, there is some window present. There is no clubbing. This is window test. I can see through both nails. This is window test for examination of clubbing. Now we are going to examine nails. There is loss of luster, but there is no pitting. Here we might find that there is some hematoma in that nail bed. No spooning. Okay. And then we are going to examine tremors. To examine tremors, we have two types of tremors, fine tremors and coarse tremors. Fine tremors in case of thyrotoxicosis. We ask the patient to stretch his arm with his fingers outstretched. And then we might put a paper on the patient fingers and see if it is movable or not. It is not movable. There is no fine tremors, and I can look at them directly. Fine tremors in cases of thyrotoxicosis. If I want to examine coarse tremors or flabby tremors, what is called also astraxas, which is present in cases of liver failure, respiratory failure, and renal failure, I ask the patient to outstretch his arm. and make his arm like that. And I should wait if it will move or not. There is no coarse tremors. If the patient do that, it is called coarse tremors, but the patient has no coarse tremors. This is very important to remember. I should also comment on the joints. There is no joint swelling here, no deformities. There is no joint swelling nor deformities. And now we finish hand examination. Now we will go for lower limb examination. In lower limb examination, we will do the same as we have done for upper limb examination. We comment on the skin, subcutaneous tissue, muscles, pulsations, joint examination, palmar erythema in the above, and nail examination. But we will focus, it is the same as we described in upper limb examination, but in lower limb examination, we will focus on lower limb edema. Lower limb edema. To examine lower limb edema, we can start by applying pressure against a bony prominence for 15 to 20 seconds. It's like that. We will start in the dorsum of the hand for 15 to 20 seconds. We look for depressions or any dimpling. There is no edema. I can also compress the medial malleoli. Another side, I might compress lower third of tibia, upper third of tibia, anterior subiatic spine, and sacrum type. What should I comment if I found edema? I should comment it is unilateral or bilateral. It's very important. It is betting or not, betting or non-betting. Non-betting edema is usually caused by lymphedema and mixed edema. I should comment on the consistency. It is either soft, firm, or hard. Hard edema in case of lymphedema. Firm edema is usually present in cardiac causes, and soft edema in causes of hypoalbuminemia. I should comment also on the upper level of edema. I don't comment on it is present or not. I should comment to know the severity of edema. It is either up to the lower third of tibia, or it is up to level of the knee, or it is generalized edema. So edema, I should comment it is either present or not, unilateral or bilateral, betting or not, consistency of edema, and the upper level of edema. Not to forget that I should look for lower limb examination between the toes to look for any fungal infections, and to do peripheral pulsations beside temperature and commenting on the skin if there is pigmentations or not, and the muscle status. Thank you.